Hi there, it's Dr. Atkinson, and today we're diving into a topic that might sound like a spelling bee challenge, but it's a serious medical issue: peritonsillar abscess, also known as quinsy. Let's break this down together. A peritonsillar abscess is the most common major suppurative complication of a sore throat. In fact, it makes up about 30% of all soft tissue head and neck abscesses. It typically shows up in adults between the ages of 20 and 40, and it doesn't discriminate between men and women. What exactly is it? Well, it's a pocket of pus that forms between the tonsillar capsule and the surrounding tissues, including the soft palate. This usually happens after a tonsillar infection that doesn't stop at inflammation. Instead, it progresses to cellulitis and then to a full-blown abscess. Now let's talk bacteria. Multiple pathogens can be involved. The most common culprits include Streptococcus pyogenes, the same one that causes strep throat, Staphylococcus aureus, Neisseria species, Corynebacterium species. If left unchecked, the infection can get ugly fast, spreading across the palate, down into the neck, and even the chest. And here's the part that should grab your attention. Severe swelling can lead to airway obstruction, which makes this a medical emergency. Complications can be life-threatening, including mediastinitis, intracranial abscess, and empyema. That's why early detection and aggressive management are key. Let's look at the clinical presentation. This is not your average sore throat. These patients are acutely ill. You'll often see a severe sore throat and fever, trismus, which means they can't open their mouth fully, drooling from the pain and muscle spasm, rancid breath, not subtle, odonophagia, or pain when swallowing, dysphagia, which is difficulty swallowing, and otalgia, or ear pain. Why the ear pain? Because of inflammation of the muscles in the pharynx, specifically the superior constrictor and medial pterygoid muscles. That inflammation triggers spasm, which makes it hard and painful to move the head or open the mouth. When you peek inside the mouth, you'll likely see redness of the anterior tonsillar pillar and soft palate, a tonsil pushed inferomedially, and the uvula pushed away from the affected side. That's called contralateral deviation. Now let's talk diagnosis. In many cases, it's the emergency department ED physician who makes the diagnosis. Imaging can help, especially intraoral or transcutaneous cervical ultrasound, to distinguish between cellulitis and an actual abscess. What about treatment? We start with antibiotics, usually penicillin, and often combine them with corticosteroids to bring the inflammation down. If caught early, the abscess might respond to medication alone. But if not, then we have to drain it. There are a few options. 1, needle aspiration, often done in the ED. It's cost-effective and tolerated well. 2, incision and drainage, slightly more invasive but sometimes necessary. 3, tonsillectomy, usually reserved for patients who are not good candidates for the other 2 procedures. Here's how needle aspiration works. We numb the area first with a topical anesthetic, then inject a local anesthetic into the swollen area. The provider then uses a needle to aspirate pus. Sometimes it needs to be repeated. If it's successful, the patient often feels immediate relief. Now, if the patient is having airway compromise, that's a different story. We may need to intubate, or in more extreme cases, perform a cricothyroidotomy or tracheotomy to secure the airway. Patients with complications often require hospitalization, IV antibiotics, and careful airway monitoring. Let's wrap up with the role of nursing care. The nurse is key in assisting with airway procedures like intubation or trach, supporting during needle aspiration, administering topical anesthetics and prescribed analgesics, helping with throat irrigations and gentle gargling using saline or alkaline solutions, usually warm, around 105 to 110 degrees Fahrenheit. The patient should be upright and able to expectorate. We encourage gentle gargling every 1 to 2 hours for up to 36 hours. Most patients do best with cool or room temperature fluids, and we make sure they're well hydrated. Before discharge, we reinforce signs of complications, good oral hygiene, foods to avoid, when they can return to work, and a strong reminder to avoid or quit smoking. So there you have it. Peritonsillar abscess is no joke, but with the right care, most patients recover fully.